Greetings. I'm Jim Shea with the Acoustic Neuroma Association, and we're happy to have you join us for this very special ANAwareness Week presentation, Facial Retraining After Acoustic Neuroma, with our longtime partner, Jackie Diels. Many of you may already be familiar with Jackie. She's been working with the ANA since 1991. Over the years, she's helped countless patients facing facial weakness or paralysis. Her depth of experience and approach have made her an expert in the field, and we're thrilled to have her with us today. Jackie will introduce herself in just a moment, but first, just a few quick notes to help you get the most out of this session. If you have a question while watching on Zoom, just type it in the Q&A box at the bottom of your screen. We may be able to address those questions throughout the session, and we'll also have time for Q&A at the end of the presentation. Captioning is available. Just click the option at the bottom of your screen to turn those on. This presentation is being recorded and will be available on our video library at anausa.org as quickly as the internet will allow. If you haven't explored that area, it's a fantastic resource with information on a wide range of topics. And finally, stay connected. Follow us on Facebook, Instagram, LinkedIn for updates on upcoming events, patient stories, and ways to stay involved with the AN community. We're here to support you every step of the way, and we're excited to bring you today's presentation as part of ANAwareness Week. So with all of that, Jackie, I'll hand it off to you, and you can kick us off.
Hello, everybody. Whoop, I'm way ahead of myself here. Good morning, everyone. I'm thrilled to be back again. Boy, Jim, you said 1991. I was a baby when I started this, actually. So it has been a long time. Next year will be 40 years that I've been doing this work. And it never ceases to be completely amazing and new every single day. I'll have a little bit more about my history here in a little while. But I wanted to start with something that we really never think about. And that is, what is facial movement? We don't think about it. It's emotional, it's spontaneous, it's unconscious, it's communicative. It's the way that we communicate with people, non-verbally. We never learn how to do it. Nobody sits their child down when they start smiling, let's say at 6 weeks old. Nobody sits their kid down in front of a mirror and says, honey, I'm going to teach you how to smile now. I want you to look in the mirror and I want you to flex your zygomatic major and minor muscles. It's spontaneous. It's an instinct, actually. Facial movement is small. It's precise and it's effortless. If I make one tiny little movement with my face, you can see that I maybe look a little bit unpleasant right now, like something smells bad or is distasteful. It's not a big movement, but that's how we communicate, with small, effortless movements. It does require a certain amount of strength. It requires flexibility. If the facial muscles are tight, they don't move as well. And it requires precise coordination amongst all of the facial muscles. And we'll get into the anatomy here in just a little while. I do want to say that just having facial movement is not the same as having expression, because I can move my face all over the place, but I'm not really expressing anything meaningful when I do that. It's a very coordinated ballet of movement of the face. And so what is facial retraining? Well, first and foremost, facial retraining is education. Education about things that we never have thought about before. Where are the muscles located? How do they move? What is normal movement even? Because nobody wakes up in the morning and says, I wonder if my face is normal today, right? You wake up in the morning and you're off to the races, right? We make a lot of assumptions about the face. How does it move? And especially after facial paralysis, when your brain says, oh my gosh, I don't even know how I used to move that. And so we'll get into this a little as we go into the anatomy. Facial retraining works mostly with feeling the movement, not with your hand, but internally. For example, everybody who's on the call right now, if I ask you to smile, and most of you probably have one side that is working just fine, and pay attention to that. If I ask you to smile without looking in a mirror, how do you know you're smiling? If I ask you to wrinkle your nose up, how do you know you're not smiling? And so the skin gives information to the brain about the movement of the face. And why that's important is because most of the movement and communication we're doing is with other people. We can't be looking at a mirror all the time. So we need to know and attend to what our face is doing by the sensation of it rather than by the look of it. And the look can be misleading. Phase 2 is identifying and stretching tight muscles, and this will be appropriate for some of you on the call, not for everyone. And then phase 3 is learning how to regain this precise, natural movement versus exercising your face. So the facial retraining program was started at the University of Wisconsin by my mentors, Richard Ballier and Paul Bacurita. It started there in 1983. I actually started in 1986, and just was blessed to be. I feel called into this work at that time. It was my first. It was my first job out of my OT school at the University of Wisconsin. My very first job and my only job. Until I started my own private practice in 1917. Yeah, 2017. I'm not that old. Oh boy. All right. And this was the only program in the country that was devoted specifically and solely to the treatment of facial paralysis caused by facial nerve disorders. So not by stroke, for example, but by actual damage or injury to the facial nerve. It does require postgraduate training because we don't get this in our college curriculum. So OTs, PTs, or speech pathologists can do this work, but they have to have specialized training to really be good at it. It is a growing practice globally. And so there are many clinics, even in the US, that are sprouting up that have dedicated facial nerve teams and facial nerve centers. And many of you, I think, have been associated with those. And certainly many are associated with the Acoustic Neuroma Association and are sponsors of it. So we're here today because we're talking about acoustic neuroma, which is a benign skull-based tumor. Some of you may have had meningiomas as well, but there are other causes of facial paralysis. So here's a very large acoustic neuroma right here. Other causes of facial paralysis include viral causes such as Bell's palsy, which many of you have probably heard of, Ramsay-Hunt syndrome, which is a type of shingles, salivary gland tumors, trauma, auto accidents, motorcycle accidents, especially if the skull has been fractured, it can cause damage to the facial nerve. Lyme disease can cause it. And there are some children who are born with facial paralysis, either on one side or on both sides. So here's the anatomy lesson, and this is really fascinating. So I kind of boil it down into a model, and there are 3 parts to this model. And it's like this system we're seeing here where there's a lamp with a bulb, and then there's a cord that connects the lamp to the generator behind the wall, and that's the brain. So we're going to look at all these 3 parts and how they intersect with each other and where the damage actually occurs when the facial nerve is impacted during surgery. So we're going to start off here at the brain and brain stem, which is the generator. That's where the electricity comes from. It's the fuse box. So this is a cross-section cartoon here of a part of the brain that controls movement of the body. And one of the things that I think is so fascinating about this is that you can see that the largest portion of this part of the brain, this is called the motor cortex, the largest portion is devoted to movement of the face. So here we have the hand. The second largest is devoted to the hand. And then we have the arm and the little tiny elbow and the back and the little butt here. And so why is there so much area of the brain devoted to facial movement? And I think it has to do with the complexity of facial movement. It's emotional, it's functional. We eat, we drink, we speak, we blink. Um, and there's multiple muscles that move the skin in multiple directions. So this is the brain. This is ultimately the brain controls the face. And then we have at the bottom of the brain, we have what's called the brainstem and nerves that come out of the brainstem. So this picture would be like if you took your brain out of your head and flipped it upside down on a table. Not recommended, by the way. And here we see underneath 12 pairs of nerves that do everything from sense of smell to vision to moving your eyes back and forth to chewing muscles to sensation of the face. And what we're looking at specifically today are nerves, cranial nerve number 7 and nerve number 8. Nerve number 7 is the facial nerve that controls facial movement. So this is the cord that plugs into the generator. And then cranial nerve number 8 is the auditory balance and hearing nerve. That's called the vestibulocochlear nerve. And on this picture here, facial nerve is green, and hearing and balance nerve is pink. And if I overlay that picture that I showed earlier, the MRI of the acoustic neuroma here, you can see why the acoustic neuroma itself or the surgery for it can impact the facial nerve, which is right here. It's right under the tumor. And surgeries have gotten better and better since 1991 for sure. And there's less and less damage being done. But sometimes there can be traction on the nerve, and the nerve can be impacted by either the tumor or by the surgery, or both. And so this is why this is such a critical area in the brain and in the brainstem. The facial nerve not only goes to the muscles of facial expression, but it also goes to the tear production gland. It goes to some of the salivary glands. It goes to some of the taste buds. So there might be an issue with kind of metallic tastes that some people will get in their mouth. And then there's a little piece of it that goes to the sensation on the back of the ear. The facial nerve comes out of the back of the skull, right behind the ear, and then it splays out on the surface. There are 5 main branches of the facial nerve. And this is like, if you think of like a big old oak tree, there's the trunk of the oak tree, which is right here. And then it has branches. And the branches branch, and they continue to branch. And they branch, and they branch, and they branch until they hit the muscles. And then they get embedded in the muscles, and the signal from the generator comes through the cord and into the muscles. There are between 6,000 and 7,000 nerve fibers within this tiny little facial nerve, which is about the size of a piece of vermicelli pasta. So it's unfathomable how delicate this structure is. So this is one of my favorite parts, and we're going to go through the muscles of the face. There are 25 muscles on each side of the face and the orbicularis oris, which is the lip muscle. They're highly resistant to fatigue and degeneration. They give very precision movements. They receive emotional as well as voluntary movement signals. So unlike the arm, which has 2 muscles and from here to here and does 2 movements like this, and it moves bones around joints, the facial muscles move skin. And the skin is infinitely mobile. And depending on which of the muscles are pulling, the skin will move in various directions. And there's no joint to stop the movement or to limit it in any way. So they move skin. The skin is kind of like a piece of fabric. So if I pull up on my shirt goes up and all the way down to my waist, if you could see it. The skin moves, the shirt moves. If I pull down on the same piece of skin on the same piece of shirt, it pulls from the shoulder down. What's going to happen if I pull up and down on the same exact piece of skin? Which way will that move? Stay tuned. Sometimes it doesn't move at all, right? Because you have opposing forces on the same piece of skin. On this diagram, you can see that every muscle is a colored area and has an arrow on it. The arrow points in the direction that the skin moves when that muscle flexes. So keep that in mind. The arrow points in the direction that the skin moves when that muscle flexes. So the first phase of neuromuscular retraining is the education phase. Where are the muscles? Which muscles create which expressions? Where are they located in the face? How do they coordinate to create expression? And how do you know which muscles are working? And so we go through all of these things with our patients. And so I'm going to very quickly go through the muscles of facial expression, where they're located, and how they move, using my niece as the model here. This is the frontalis movement muscle. You can see the arrow points up here. And this is Sarah, and I'm asking her to raise her eyebrows up. And you can see her eyebrows are raising, nothing else is moving in her face. This muscle is called the corrugator. Arrow points down. This is the muscle that brings the eyebrows down and together, as in a scowl. This is orbicularis oculi. It's a circular muscle. It goes all the way around the eye. And when it activates, it closes the eye. So we have two parts. There's the upper portion that mostly is responsible for the upper lid closure, and then the whole circle moves when we close our eyes very, very tightly. And here's a person who had acoustic neuroma surgery, and you can see that her right eye does not close all the way, and some of you, I'm sure, are dealing with this issue as well. So when there's weakness, the eyelid can't close all the way. This is where it gets really interesting to me, and that is the smile muscle. So there are two muscles. Out of the 25, there are only two that smile, and they're actually located in the cheek. And you can tell when I smile, for example, that my cheek bulks up. We get these apples of our cheek. But I see that there are many people, most people think we smile with our mouth because that's what the eye sees. The eye looks at the mouth and sees that the mouth is moving. But the reason the mouth is moving is because the bottom ends of the smile muscles are attached to the corner of the mouth. And so when they flex here, the corner of the mouth is raised. But the movement comes from here, not from here. This is the response to the movement here. And you can see Sarah smiling here and then a big open mouth smile. So sometimes just going through the education with people is very instructive and they learn something just from the education. So for example, here's a woman, she actually had Bell's palsy about 20 years before this picture was taken. And this was her initial evaluation, and she came in, and this was her initial smile. And what I said to her during the evaluation was, all right, and you can see she's not smiling on her left side. I think she's trying to move her mouth, I'm not sure. And what I asked her to do is I said, okay, now instead of smiling, what I want you to do is think about smiling by raising your upper cheek And immediately after this picture, she did this. So she put her hand up and she said, "Oh my gosh, I haven't felt that in years." So just identifying where to put the brain to activate the muscle can is always helpful. Now you can see that it's not perfect, and so there are other issues going on here, but it's a start. These muscles are called the levators. These are the muscles that wrinkle the nose up like something smells bad. The risorius is the smirk muscle. This is the muscle that pulls the corner of the mouth back like somebody told a bad joke. Here's the orbicularis oris. This is the only muscle that pulls the lips toward the center of the face. It does a number of different things. It presses, it rolls in, it puckers, and it protrudes forward like a whistle. This is the frown muscle called depressor anguli oris. This is the muscle that turns the corners of the mouth down like a sad clown frown. This is called depressor labii inferioris. This is the muscle that shows the lower teeth. The mentalis muscle is the muscle that pushes the chin up toward the nose. It creates this chin dimple, which many of you, I'm sure, have seen on yourself. The buccinator muscle is inside the cheek. It pulls the cheek tightly against the teeth. It's the baby's sucking muscle, and it's a muscle that we use to move food back and forth between the two sides of our mouth when we chew. The platysma muscle is located on the neck. We don't really recognize it so much as a facial nerve muscle, but it is a facial nerve muscle, even though it's on the neck. This muscle shows expressions of anxiety, sadness, dissatisfaction, and suffering. We don't use it much, but for those of you who have tightness and a condition called synkinesis, you may see cords develop on your neck, and that's this muscle that's doing that. There are 4 different treatment categories that I work with. Flaccid paralysis, which is no movement at all. Paresis is weakness, so it's the flaccid paralysis that's recovering. Synkinesis, which is abnormal movement that occurs during normal movement, and then people who've undergone surgical reanimation. We're going to be talking specifically today about the flaccid paralysis and synkinesis. So here's a patient 10 days after acoustic neuroma surgery. The pictures you're going to see were taken by her husband to just show her progress over time. So this is 10 days after her surgery and 2 months after surgery. And you can see that maybe it's a little better. The lower lip's not drooping as much. Here is 4 months after surgery, and her smile is back. Look, it looks great. Her eyes are covered in these pictures, but if you saw her right eye, you would see that it's quite wide open still at the 4-month period of time. At 6 months, there is better movement, maybe. It's a little different. Maybe it's not quite as even as it was at 4 months. And then at 14 months, I got a call from her saying, I was getting better and better and better, and now I'm getting worse again. And at her initial evaluation, which was at 15 months, she came in, and this is what her initial evaluation looked like right here. So how is it? And you can see that the smile is really not as good as it was at 4 months. So what happened here? What changed? Did she lose function? I don't think so, because you can even see that she doesn't have a full bulky cheek on this side like she has on this side. And it's certainly fuller here, and yet the corner of her mouth isn't going up. So what happened in that time between 4 months and 15 months? Well, it depends how you look at it. So some of you who are looking at this slide right now will see a lady walking through a park. Others of you will see a face. So how are we looking at facial dysfunction? How do we interpret it? So here we see two people. At first glance, both of them look like they have facial paralysis on their right side, which they do, but it kind of looks different, doesn't it? You can see on the gentleman, there's no cheek bulking, no activity. He's got this low-hanging eye, issues with eye closure, clearly. And you can see on her, she's got this big bulky cheek. And so since we know that the smile muscles are here, why is it that it looks like she's not smiling? So if we look closer, we can see all of these neck cords pulling down the corner of her mouth at the same time that she's trying to raise it. So you have to be really careful about knowing what you're looking at, because at first glance, it looks like they're the same thing, and they're actually opposite of each other. And this is flaccid paralysis on the left and synkinesis on the right. And here both of them are puckering, and you can see that on the gentleman, his mouth is going toward the stronger side, which is his left side, and on the lady, it's going to her stronger but uncoordinated side, which is her right side. So what do we do to manage flaccid paralysis? Eye care is first and foremost. It's the most important thing. We stroke or tap the affected side to maintain the sensation connection with the brain. It does not stimulate the muscles to move. It just helps the brain remember that the face is there because it's not getting signals that there's any motion going on. We don't exercise at this phase. There's no nerve signal. The cord right now is unplugged from the wall, and you can flip the switch as many times as you want and it won't go on. Only the affected side moves, and that can cause more imbalance and more asymmetry. We have people attend to pay attention to the easy movement of the normal side, of the unaffected side. It's never forced, it's never exaggerated, it's soft, it's fluid, and by paying attention to the feel of it, it seems that the affected side recovers better, that it knows more what to do as movement is coming back. And I tell people to just let it heal. You don't walk on a broken leg, you let it heal first. We do not recommend electrical stimulation. The research findings are that it's not effective. It may interfere with nerve regeneration. It can reinforce abnormal movement patterns because it's not very selective. It makes many muscles contract all at the same time. It doesn't train function or expression, and it doesn't generate a feeling of emotion. So we don't recommend it. Some practical tips for flaccid paralysis: see the ophthalmologist regularly, especially if you're having any kind of issues. Use drops and gel, and I'm sure those of you on the call already know all of these things. Use protective barriers, sunglasses, moisture chamber, to keep especially if you're out in the wind, to keep everything protected. You can get cool looking motorcycle sunglasses that actually wrap around and protect the wind from coming in at the sides. And then there are ways to use tape to support especially the lower eyelid up in the early stages. And the Facial Palsy UK website is a great resource, and I have information for that at the end of the presentation, the website. Oral care, cutting food in small pieces, chewing on the unaffected side. Go ahead. Don't try to force yourself to chew on the affected side. It doesn't help the recovery, and it's awkward. And you know that better than I do. So just go ahead and chew on the unaffected side. The dentist that I confer with says that it's not a problem, and you won't hurt your teeth or your jaw by doing that. You can reduce your speed of speaking, eating, and drinking. And for food pocketing, oral hygiene, I highly recommend a water pick, just to to kind of get in there because your tongue can't get in there easily to remove the food. And then for those of you who might have a collapsed nostril, because there are lots of muscles inside the nose, I didn't talk about them, but they're there. The nostril can be collapsed when you breathe in, and especially when you lay down to sleep. You can use breathe right strips for that. Here's a case study. This is Paul. You saw a picture of him earlier. Paul actually had Bell's palsy. And by the way, the retraining we do doesn't matter if someone has a facial nerve injury from Bell's palsy or an acoustic neuroma or from trauma. It's like breaking your leg. It goes in a cast whether you broke it falling down the stairs or in an auto accident or in a ski accident. So the treatment is the same and is based on what we see. It's based on the actual function of the person. So some of these slides that you're seeing, these people have had Bell's palsy as well. So here's Paul, and this was 2 months after the onset of his Bell's palsy and at his initial evaluation. And then he came back a couple of months later and said, it's not getting better, it's not getting better. I take photos of people every single session because it's hard to see the small changes that occur over the course of months, weeks and months. And so you can clearly see that it is better in the second picture. The corner of the mouth isn't as turned down. It's starting to come up. The pucker is better. The eye actually looks a little bit better too. And then at about the 6-month mark, this is what Paul looked like. And this is not, I will say, this is not because of facial retraining. This is because of spontaneous recovery. So there were no exercises that Paul did here. There were no exercises Paul did here. And then when I saw him again in May, we decided he didn't need any exercises really. So this is spontaneous recovery. It's not facial retraining. So synkinesis is an entirely different animal. Synkinesis is abnormal movement. It's abnormal synchronization of the facial muscles that results in a distorted expression. So you can see this gal who did have an acoustic neuroma. This is her affected side, and you can see she's got a lot of cheek bulking. So we know her smile muscle is working. It's not flat and flaccid, and yet she doesn't have a great smile. So this is caused by a cross-wiring of the facial nerve during recovery, where the nerve fibers, as they heal, they can implant themselves into muscles that they weren't in before. It overcorrects. I have a colleague who calls it hot wiring, that the face gets kind of hot wired. And so where you see the red arrows, that's where we see the hot wiring happen. There are abnormal movements going on, and where the green arrows are that's where what I was asking her to move. So I asked her to smile, and so she did, but you have all of this extra movement going on in these areas, and you can see the neck cords that I was referring to a little bit earlier. So in synkinesis, the limited movement is caused by a lack of mobility and in coordination, not a lack of strength. It's when I pulled on my shirt, it's 2 or more muscles that are pulling against each other simultaneously, not allowing full movement in either direction. It appears to be weakness, because when the eye sees it, it sees that the corner of the mouth isn't going up. The retraining for synkinesis is counterintuitive. Increasing the strength does not increase the movement. It doesn't improve the movement. What improves the movement is learning how to coordinate better. So to do that, we go to phase 2. We identify the tightness. And so what this lady is doing is she's puckering her lips. And you can see on her left side, she's got a nice pucker. Everything else is quiet. On her right side, you can see that she has a deep crease on the side of her nose called the nasolabial fold. She's got a kind of a puffy cheek, and that's because her smile muscles are pulling at the same time. And you can see all of this highlighted in these red arrows on this side of the diagram. She's got a smaller eye. That means her eye closure muscle is contracting simultaneously. The corner of her mouth is pulled back, and that would be either that buccinator muscle or the risorius muscle pulling toward the ear. She's got the chin dimple. The chin is pushing up from the bottom. She's got the neck cords pulling, the platysma muscle pulling down, the neck bands. And so all of these muscles are fighting for movement of the skin simultaneously. And it's very uncomfortable, and the muscles get very tight. And so for the tight muscles, we do soft tissue mobilization, which consists of stretching the muscles, and we do the muscle groups kind of individually. We do massage, and we can use heat on. I have patients using heat on the muscles, especially at night, to kind of calm them down when they go to bed. These pictures that you see here are techniques that one of my patients was using for her face, but everybody gets individualized treatment depending on where their tightness is and where they're having issues. So here's a patient 1 month after starting, and she was a year and a half after acoustic neuroma. And you can see she's smiling. She has doing a closed smile in this picture, and you can see her left side is quite tight. But you can see she's got good bulking. So after 1 month of doing the stretches and the soft tissue mobilization, you can see she has more mobility. These are not exercises, they're actually stretching tight muscles. It's kind of like if you have a Charlie horse or a cramp in your leg muscle, you wouldn't tell your friend, oh, I'm sorry, I can't go for a walk with you today because my leg is paralyzed. You'd say, oh, I got a cramp, I've got a Charlie horse. So this is what we're dealing with synkinesis, is these cramps in the face that limit fluid movement. And here she is puckering her mouth, and you can see that on her left side, the pucker is being pulled to the side. You can see she has some neck tightness here, and the eye is closing. The cheek is quite bulky. And after 1 month, it's better. It's not done, and this is always the first phase. We have to stretch the muscles before we coordinate them. You can't coordinate a tight muscle. And here she is with the open smile, and you can see that she has much better opening, and this is just after stretching for 1 month, but very directed stretches. And so on phase 3, what we're working with is retraining the actual synkinesis. The abnormal movements distort expression, and in this picture down in the lower right, you can see the various arrows on the muscles, and they're all pulling against each other. We find the address of the muscle. Where is it located? Going back to the education, where is it located? What are we trying to move? We use the unaffected side as the model. What is moving on the unaffected side? And then what's moving that shouldn't be moving on the affected side? Where are all the red arrows? And so we identify those. Sometimes I have people mimic that on their unaffected side just to gain insight as to what's gone wrong here. And the real work that we're doing in the retraining phase 3 is teaching people how to maintain quiet in the muscles that should not be working. In other words, we're training people what not to move in order to allow what's supposed to move without any restriction at all, to the extent possible. Movements are always small. They're always precise because that's normal in the face. My question when I'm working with people is not how big can you do that, but how small can you make it? And know that you're doing it without anything else coming in and becoming tight. Because the smaller and more precise you can make it, the easier your brain will learn the proper pattern. It's like if you're learning how to play piano and you keep hitting all the wrong notes, you'll have a much harder time learning how to play Beethoven than if you just hit the notes that you need for the piece that you're playing. We don't use a mirror for retraining. We go by that sensory feedback because the eye is deceptive. The eye always looks at the corner of the mouth. Am I smiling yet? Am I smiling yet? But the eye needs to look at the cheek. Is it lifting? And then if it's, is the cheek lifting? And then if the corner of the mouth isn't going up or isn't opening, we have to identify why. What's restricting that movement in that area? Working with a trained facial retraining specialist is really important because we don't get this training of how to work with the face in our college curriculum. So I mentioned it before, and I will mention it probably a couple more times. Find a trained specialist. There aren't very many of us. We are training people as fast as we can. But when it comes to people who have physical issues, the population of people who have facial paralysis is much smaller and getting smaller all the time, thank God. But it's much smaller than people who have hip replacements, for example, or knee injuries or strokes. And so much or sports injuries, that's a big area that therapists get trained in. And so this is a specialized training program. Synkinesis is kind of like this four-way tug of war, where all these people here are pulling with all their might, and yet the ropes aren't moving. And so what we need to do is we need to identify which rope needs to be moving, and we need to get the other guys to stop pulling. The goal here is precision, not power. We're not trying to strengthen muscles when we're talking about synkinesis. What we are doing is strengthening the brain's ability to access them accurately. Here is a patient who had an acoustic neuroma, and this is an older slide in 2010. She's someone I've worked with for quite a long time. And what we were mainly working on with her, there were a lot of issues to work on, but in this slide, what you see is here's the DAO muscle that's pulling down, and she has learned how to stop pulling it down. So it doesn't look like she's frowning. And she said, I always feel like people think I'm grumpy, and I'm not grumpy. And that's because that's a kind of a grumpy muscle. And so she's done very well. And you can see that her neck is better. It's still there some. And we've been able to get rid of most of her chin dimple. And then here's another patient after Bell's palsy who was trying so hard to pull her lower lip down to show her lower teeth. And she was using so much effort. Increasing her effort made the synkinesis much worse, and it didn't help the lower lip. And so now you can see with less effort, she has less of the restriction and the counter pulls, and she gets a much better lower lip. It's not perfect. And so here's a lady. I love to show this lady. She had Bell's palsy 30 years before I saw her, and then she had her kids, and she said she was busy working full time, and she just didn't have time and to work on her face. And then she retired, and she sought out treatment. And you can see that this was her initial evaluation in December of 20, and then this was after only doing soft tissue mobilization work for 4 months, and this is her in June. And you can see there are still issues. You can still see neck cords, and this isn't completely up, but it is much better. She was very happy. She was a great patient. Of course, we show all of our best patients. But everybody is different and everybody has different outcomes, and those outcomes are based on so many factors. How much damage was there to the nerve? How well do people practice? Are you practicing piano once a week, or are you practicing piano 3 hours a day? And so there is a lot of variability, but what we see in general is improved comfort, more natural expression. Um, we know through research that the gains that are acquired are retained even after someone goes through the program and doesn't do it anymore. There are retrospective studies that demonstrate effectiveness of facial retraining. There are prospective studies that have been published that show effectiveness, and there are many studies right now that are underway in our field. But I do want to say that the outcome through facial retraining is never perfect. There is nerve damage, and especially in cases of synkinesis and in flaccid paralysis too. So the retraining is never perfect. It makes people better, but never perfect. So just by way of comparison, review, there are 25 muscles of the face and they move skin. It's unlimited by joints. We create somewhere between 2,000 and 3,000 distinctly different, recognizable expressions that we never learn. The facial muscles are used to communicate, not to lift heavy objects. Increasing their strength does not necessarily increase their function, although we do need some strength. Comparing that to the arm, for example, we have a few muscles that move bones around joints, which limits their range of motion. There are no emotional cues, happy or sad. Your arm is going to do this every time. And increasing strength does increase function in our skeletal muscles. Every face, every surgery, every viral infection, and every recovery is unique. Every person requires and deserves individualized evaluation and treatment because we all start off with different faces. And after something like this, we all end up with different faces too. This is a patient-centered program that provides excellent continuity of care after acoustic neuroma surgery. It's cost effective because therapy is done not once a week or twice a week, but in my practice, I see people at the beginning, maybe once every 2 months, but they're given homework. And so we train people to train themselves. And this is a program that provides specific training for the unique characteristics of the facial neuromuscular system, how it connects to the brain, how the nerve connects to the muscles, and how the muscles themselves work. Facial muscles are the only ones whose principal role is to move other people. And so with that, thank you for your attention. We have some time to take questions. And then here on this page, I wanted to give the website of Facial Palsy UK. It's an excellent resource. There's a self-help area. Of course, what they have on the self-help area in terms of stretches and other suggestions for how to care for both flaccid paralysis and synkinesis, it's quite generic. So it's not detailed as to your specific face, but it definitely will give some ideas of where to start.
Jackie, that was terrific, very comprehensive. If you want to just stop sharing your screen, we do have a handful of questions.
All right.
And, to our viewers, just a reminder that this presentation is going to be in our video library. We have one of the more popular topics that comes up is time frame. When is too early? When is too late? If a patient is a few years out, a decade or even 2 decades out since their acoustic neuroma treatment, they've had some degree of paralysis. Is there something that can be done along the different time frames, or does it help to do it earlier, or how would that work?
Yeah, that's a great question. I'm going to remember to put that in my slides next time. So for people, let's start with people who are far, far out. So that last person that I showed you with the three pictures, she was 30 years out. So if there is movement, there is no time limit to when we can work. If there's synkinesis, there's no time limit because we know we have live muscles. We've got a live nerve, we've got live muscles, we have uncoordinated movement. So that would be like me saying that no matter how old I am, if I'm if I'm 80 years old and I want to learn how to play piano, I've got the muscles and the nerves to be able to learn how to coordinate it. So there is no time limit on that. If, on the other hand, somebody comes up at 30 years and they have flaccid paralysis and no movement at all, facial retraining will not be beneficial for them. So, starting back at the beginning of the spectrum, I personally, in my practice, don't see people until there are signs of recovery because if the nerve hasn't kicked in yet, if there's nothing, if there's no sign of movement, then there isn't anything to work on, and we're still waiting for recovery. If I had the opportunity, and I know many clinics do this, and I think it's a great idea, if I had the opportunity to see someone early on, to teach them what to look for, how to care for their eye, how to massage perhaps the unaffected side of the face so it doesn't take over, and just give some guidance, I think, and some of these practical tips that I outlined in my talk, I would take the opportunity to do that. But that would be sort of a one-time session and more of a monitoring until movement came back and we could really start practicing very small, precise movements, never movements with effort, because effort movements are never normal in the face. We just don't do that.
Whenever we do this, I'm always very cognizant now of the movements. And you're right, they're not something you feel like you're doing. Um,
Right. You just raised your eyebrows just a little bit. That's it. That's all we do. We never do this.
Absolutely.
We want
Along,
to, I'm
I'm sorry,
sorry.
I was going to say along those same lines, is there anything a patient can do prior to treatment that may help them without, help them with the retraining afterwards or having to do less retraining afterwards?
You mean after the surgery? Uh,
Surgery.
paying attention to the unaffected side. Pay attention. We don't ever think about, well, what is the food doing in my mouth when I'm chewing? How is how is the food being manipulated by the tongue and the cheek? And just noticing noticing the feel of the face. That is always something to pay attention to. The other thing is to, right after surgery, is to stroke the affected side. We're not trying to stimulate it in any way, but when the face isn't moving, the sensation part of the brain isn't getting signals that the face is alive. It's just dormant because we're constantly getting signals that we're doing stuff with our face, that we're making expressions. And if the face isn't moving, the brain isn't getting that feedback that it's there. And so just stroking it tells your brain, oh yeah, I feel it. It's still there. And then
Okay.
tapping was something else that I had that I had mentioned on the slide. Yeah.
Okay. Another topic that comes up quite a bit. Can you talk a little bit about the use of Botox? And I know we've had a question about Botox and synkinesis or something like that. Go ahead and you can.
Botox is great. As a matter of fact, Botox is great in certain situations. Um, um, that's a whole another hour-long talk. But I like to work with people for 6 months before using Botox. And where we typically like to use Botox is in the muscles that I'm going to use the word expendable. So, for example, people who have a lot of pulling in that neck muscle, Botox in that platysma, Botox is great in that muscle because it's not a muscle that we use often, and there's no downside to it. So if we get Botox there, it stops a lot of the downward pulling at the bottom of the face and allows these muscles to pull up without so much interference. Another area that we use Botox very often is around the eye. Because if in synkinesis, if the eye becomes very tight and it closes, when we eat, drink, speak, smile, it squints closed all the time. Um, it's really uncomfortable and it doesn't look great, right? And so we use Botox around there, but there you have to be very judicious with Botox because we're treading a fine line between enough Botox to take the edge off of the tightness and not so much Botox that the eye doesn't blink and it gets dry. And so you work with your facial plastic reconstructive surgeon or the oculoplastic surgeon, and they'll know how much Botox to put in there to kind of get you in the right place. It's never perfect in either direction where we can get rid of all the tightness without getting dryness. So there's a kind of a compromise in there. And just a word about Botox on the unaffected side. I personally am not a fan. And around the like the crow's feet or in the brow, that's okay. But in the lower face, we use that as a model for good movement on the affected side. And so I am not a fan of decreasing or changing the movement pattern on the unaffected side. Um, for that reason, that's my preference. Um, and I want to say that the reason that I wait for 6 months before considering Botox is because when we use Botox right away, the brain doesn't have the opportunity to learn, to untangle the spaghetti of synkinesis strands. And in anything we do, the learning is in the struggle of figuring it out in anything we do. If our children are learning how to walk and they fall, we don't pick them up. They learn. And so there's that brain learning process and that we can do in the first 6 months of retraining that if we use Botox, we don't have that opportunity.
Well, we're running up on time, and that's a pretty good note to end on.
Okay.
So
Yeah.
thank you so much. I know you've been doing this with us for such a long time. You've been in our notes newsletter. You've been doing webinars and things like that. And you've been appearing at patient support group meetings. Thank you so much for all that you do. It's all encompassing, and we really do appreciate it. And I always learn something new.
Well, you're very welcome. And we have some really great new young people coming up in the field that I'm excited to share with you in the coming months.
So that's certainly something we love to hear. So
yeah.
you're sharing knowledge.
All right.
Thank you, Jackie, and thanks to everyone out there watching us. Again, this video will be on our website, and we're going to continue with ANAwareness Week. So thank you so much.
Thank you very much.